we were talking about your involvement with the ME Trust. When you applied for that job and thereafter, when you had it, were you also seeing patients in your capacity as a GP who had symptoms of post-viral infection from COVID?
Yes, so I had a mix of patients. I had patients who'd maybe had ME for a long time, and then I had patients who'd had COVID who weren't getting better as they'd expected, and had looked to see what was available and saw me either with the ME Trust or in my own practices. They would seek me out. But yes, lots of patients in 2020 and into 2021-22.
You tell us in paragraph 15 that you noticed that ME patients and those who had COVID had quite similar autonomic and allergic problems as part of what was wrong with them. Can you just explain what autonomic means?
Autonomic is a word that is similar to automatic. So your body does something that you don't have to control, like your heart beating, or you're not consciously aware of that. And it can be connected to your brain, and signals between those are autonomic.
And what were the similarities?
There was a high prevalence of a condition called postural orthostatic tachycardia syndrome.
That's POTS, I think.
POTS, yep. And that was very obvious to me very early on that these patients shared POTS in common. And also that they were more likely to be allergic to things randomly. They could be allergic to things. Their immune systems were overreacting to things they wouldn't usually. And they also had post-exertional malaise, a lot of them. So in common, there was these particular features.
Right. Now, you had also, I think we can see this in your background, you have some experience of cardiology and also rheumatology. Is that right?
Yeah.
And were you able to bring those experiences to bear in relation to these patients?
Yeah, so I supervised what's called tilt testing in Dumfries and Galloway. It would be about 10 years ago now.
Right. Can I just pause you there? Can you tell us what tilt testing is?
So tilt testing, POTS is when the blood in your body should, when you stand up, it should go up to your brain, and that should happen automatically. And if it doesn't, the blood is not getting to your brain, and your heart rate speeds up. And one way of testing it is with a tilt test, where you attach somebody to a bed and you essentially tilt it up and you watch what happens to the heart rate. So it's fairly niche to be supervising those tests, and it just happened in one of my rotations. I was supervising, so I knew about POTS, and I would say that it's not as well known about in medicine as it should be or could be. I already knew about this condition and recognised it very quickly.
And in relation to those people who are presenting symptoms post COVID infection, was POTS an issue?
A massive issue.
I think you've given an indication of, I think it's 80% of your patients. You identified that as an issue with them.
Yeah, and the prevalence in research papers would be between 40 and 80%, depending on what group of patients you're looking at post-COVID. But certainly the patients that I've seen, most of them have POTS that hasn't already been diagnosed. So they've often had it since they've had COVID, and it's not been diagnosed in these patients.
Right. You tell us also at paragraph 19 that you attended your local health board meetings on what to do about long COVID and gave your own perspective. Now, just before I ask you some questions about that, the term long COVID, when did that start to assume prevalence in medical parlance, if I can put it that way?
So the term long COVID was coined by patients mid-2020.
Right.
And there are other terms used in medicine. Post-acute COVID syndrome is one of them. But long COVID has stuck, as it were, as I would say.
It's a simple term.
Yeah, it's a simple term that I think everybody understands.
Yeah.
Yeah.
Good. Okay. So you were providing your own perspective at health board meetings, and you tell us that you were cautioning that physiotherapists and occupational therapists were burning out. Can you explain why that was happening?
So the patients were referred, and every health board is different. The one I was in, the patients were referred directly in from their general practitioners. So they might have had some blood tests. They might have had a chest x-ray. What they hadn't had was a full physical history examination and investigations by somebody who knew more about long COVID than they did. And the physiotherapists were trying to work with people who had POTS, who every time they stood up their heart rates doubled, and they couldn't do the rehab they were being asked to do. And that's very difficult for those physiotherapists because they could recognise the problem, but there was nobody there for them to ask for treatment or advice. So they were essentially trying to rehabilitate people with the rehabilitation model who needed more medical input first.
Okay. All right. And you tell us that you were met with the comment, which I think is probably apocryphal, but you've given it. People just need to exercise.
Very common.
Who were you getting that response from?
So from other doctors, that these patients weren't trying hard enough, that they just needed to get back to what they were doing and build it up, and they would be fine after that, and they didn't need anything else.
At that time, and in your view, was exercise beneficial to patients who were presenting with these symptoms?
No, because we know from ME and the change in the NICE guidance in 2021 that exercise was taken out of the NICE guidance for these patients, graded exercise, because they found when they re-examined the studies that it wasn't beneficial and could be harmful. And given many of the long COVID patients, about 50% of those meet the ME criteria, that they were unlikely to not only not benefit, but for it to be harmful without it being properly supervised and individualised plans for people. So it may not be the case for every single patient, but certainly for at least half of them could be potentially harmful.
So as a piece of generalised advice to effectively get out and exercise was not particularly helpful.
No.
And I think you say that this has since been confirmed in studies. You haven't given the details, but you've obviously seen these studies.
I have. I've seen the most recent one is that in about 1/3 of patients that they studied, there was muscle necrosis, which meant that the muscles were breaking down and dying after exercise. And there was about 2 weeks for those muscles to regenerate.
Okay. You do tell us, and don't worry about naming this individual, in the next paragraph, because it's an individual who is well known. You were at an awards ceremony for long COVID kids, and you say that you're one of their champions.
Yes.
And we'll come to long COVID and children at a later stage in your evidence. But at that ceremony, you spoke to the then Health Secretary, Hamza Yusuf, and who is now First Minister, obviously, and you gave him certain advice and information. Can you tell me what you told him?
So we had a chance before the ceremony to mix, and I said that the model that we had for long COVID patients wasn't working and wasn't going to work, which was the model of sending people to physiotherapy and occupational therapy without a medical person involved in that. And he listened and said we should have a chat sometime properly about it.
And did that subsequently happen?
So I did have a chat with him, with Helen Goss of Long COVID Kids, and she and I both put the same point across in the meeting in 2023. But it was a proper meeting to talk about the model of healthcare and also about the dangers of COVID and what it can do to the blood vessel system. And we also discussed that and my concerns about the effect on the population of repeated COVID infections.
Now, with this basis of experience, you set up your own long COVID clinic, and we can read about that. First of all, why did you decide to do that?
So having attended health board meetings and tried to put across that I felt having a doctor that knew about conditions like this and having worked with the ME Trust, felt I had that experience to see if that worked better. When the money was awarded in 2022 for health boards, there just wasn't the money for the area to employ a doctor to do that. And at that point I realised I'm either going to just not do any work at all on this at all, or stick to my own practice where I might have, half a dozen long COVID patients, and that's it. And the only other way to do it would be to set my own clinic up and see what happened. So I just sort of did it and thought I'll see what happens, and very quickly booked up for 6 months fully with patients desperate to be seen.
How was your identity made known as somebody who was providing this service?
I think it was mainly patients telling other patients, I've seen this doctor and she can offer more than. I've never advertised my services. It's just sort of known that I have my long COVID clinic. I also see ME patients there, POTS patients, and I have this clinic, and patients find me.
Right. The clinic is private, is that right?
Yeah.
How does that sit with your general philosophy towards the provision of healthcare?
So I grew up in a household where we probably couldn't have afforded to go to private healthcare, and I wrestled with it a lot because I really believe in the NHS and free healthcare for all, but it was either nothing or offering something. So in the end I thought, well, maybe I can do this, and maybe the NHS could learn from this, and maybe I could help implement it. But doing nothing to me was worse than doing something. But no, it doesn't sit well. But currently still is the only way I can provide those services.
Okay. You personally have had COVID several times.
Yeah.
How many?
6.
It's confusing my breath, and that's an awful lot.
Yeah.
Or it seems to my ignorant.
I think occupational hazard.
Is that what it is?
Yeah, it's part of it. I think being a doctor, and we were around a lot of COVID.
Yeah.
I'll come to symptoms of COVID in a little with you, and we've heard, and I know you were aware, we heard from Mrs. Ormrod this morning about symptoms. So we will look at that in due course. But can I just ask you, from your perspective, what effect treating patients with long COVID has had on you? And I'm not talking about being repeatedly infected with COVID, yes. Just upon your ability to do it.
So the effect on the patients?
No, on you.
Oh, on me. So I do all of this on my own, and I don't have much administration support. I have very desperate patients who are about to lose their jobs, who might have to retire early, who need support. So I'm supporting lots and lots of people all at once. So yeah, I've taken on a lot. I would say as a person.
You do touch on this at paragraph 129 of your statement, and this is in the context of mental health impacts, and you do talk about the need to protect your own mental health.
Yeah, so
How do you do that?
I'm very lucky in that because of social media, I've managed to make connections with other doctors who are interested and want to learn about long COVID and to help people. And so I have lots of people that I can speak to and that I hadn't met before I started working with long COVID. And so there's always somebody at the end of the phone, especially if you've had a very difficult case and you work on your own. You might have had a very, an upsetting consultation. There's always somebody that I could speak to.
Well, I think that's possibly the point I'm wanting to get from you, Doctor, is that some, as you put it, some of the horror stories that you hear are clearly very distressing, and I'm just interested at the how you cope with those.
I think I cope with it because I'm a doctor and I need to help them. And that's my job. So as a professional, that's my job, to help these people in their time of need.
How many patients do you see a week?
So it's around 16 per week, and they need a lot. I need an hour with each person to see them.
And what does a consultation with you involve?
So it can either be in person or by video link, and I do a full history of, before somebody had COVID, what their life was like, the symptoms of COVID, what they've had since, any investigations, examining them, checking if they've got POTS, and then going through a treatment plan. So it usually takes about an hour, and then they get a letter back to their doctor or their GP with what we've talked about, and a plan, and sometimes referral on to other people.
Right. And so you don't refer back, you report back to the patient's GP.
Yeah.
Will the patient have come to you with a diagnosis of long COVID, or are you the provider of that diagnosis?
Most of the time they have a diagnosis from their doctor, and they've been on waiting lists for NHS services and they're still waiting, or they've decided they want to see me because they've heard about me. But generally they've got diagnosis. Some people, it turns out to be another diagnosis, so that's part of the job as well, is making sure they've definitely got long COVID. But I would say most people have the diagnosis, or are looking for confirmation of that diagnosis sometimes too.
And are you in a position, having made a diagnosis, and I suppose depending upon the nature of that diagnosis, offer treatment to that patient?
Yes, so there is, although none of the guidances that we have treatment in them, there are treatments for some of the problems that the patients have, like POTS, like their hyperimmune, so their immune system being overactive. There are treatments from other conditions that we can draw from. There's treatment for fatigue and MS, for example. We can draw from that. And so there are treatments that we can use. They just aren't in the national guidelines yet because they were made a couple of years ago and they've never been updated.
What about a referral to specialists? Do you do that?
So you can refer from private into the NHS. That's in the NHS constitution. And so it would be depending. Most of my patients don't have much money. So they're not the usual people that would be accessing private care, and they don't have the money for lots of referrals and tests. They don't have private insurance. So if they, for example, are having chest pain, then I would refer to a cardiologist and say, could you please investigate this chest pain in particular, make sure it's not this, or have they got myocarditis, for example. Sometimes the GP will do it, but I try and do as many as I can. Some specialists haven't accepted those referrals because they are from private provider and not NHS.
Right. One of the things we heard from Mrs. Ormerod this morning was one of the difficulties in a GP referring on a patient with, as she put it, a myriad of various symptoms, is to identify the specialist to whom that referral should be made. And she used the word, this does not allow for a holistic approach. Is that something that you recognise?
Yes. So, like I said, if they've got chest pain, cardiology, if they're short of breath, respiratory, neurological symptoms, neurology, and these professionals don't tend to communicate with each other. And what you get is patients that go to different clinics after a different length of time with it's not this, it's not that. That's usually the outcome, is it's not this, it's not that. Not everybody gets all of the investigations that I think they should have. So with relation to chest pain, for example, they might just get a phone call and that's their appointment and not have any investigations done. So they come back often no further forward than they were at the start of that. So there isn't one person or a group of people working together looking at that one person and what might be causing their symptoms. And some of the things that can cause chest pain in long COVID can be serious. So they can be blood clots. They can be inflammation of the heart. So it's not, you're looking for serious outcomes of this disease, and without people communicating together, the cardiologist might say, well, it's not myocarditis, but then you might have the question, well, is it a blood clot? Back to the different specialty.
Okay. Sorry, there was one point, and it's my fault. I should have asked you about this earlier. Paragraph 11, don't need to look at it, but you do mention there that you sit on an advisory group for long COVID run by the World Health Network.
Yeah.
Can you just tell us a little bit about that?
So the World Health Network has a group of doctors like myself who are interested in COVID and long COVID, and we meet every 2 weeks to discuss research. We are currently writing a paper on treatment, and we've given public talks on it for the public if they're interested, and we've done a variety of public things for people to learn more if they want to.
I think you specifically mentioned that it's an apolitical organisation.
Yep.
Is there any significance in saying that?
I think they just present the science as the science is. So that is what I mean by that. Is there's no
overlay.
No, that's what we present and what they present is what the science is telling us, and that's what's presented to anyone that's interested in learning more about it.
Okay. Right, can we turn to some of the specifics of long COVID? Now, Mrs. Ormerod this morning in her statement provided us with the World Health Organization definition of long COVID. You'll be aware of that. Is that the accepted definition of long COVID now?
It is. The only differences you sometimes get with definitions is the length of time.
Right. Yes, there are months and
yeah. So the ONS study that was monitoring long COVID was 4 weeks, for example, ongoing symptoms post 4 weeks. Then we've got 3 months for the WHO. So I think the accepted is usually 3 months, I would say, if somebody's not better in that time, that you can call it long COVID, because a proportion of people will recover in the first 3 months.
Right. One thing I'd like your thoughts on, and it's something that we've addressed with a number of witnesses, but I'd like your thoughts on it, and that's the skepticism that surrounded long COVID, particularly in the early days of the pandemic, and which may still exist. As a medical practitioner with a degree of expertise in treating long COVID, do you have any comment to make on that?
I think this is comes from what's happened with ME/CFS over the years of the history of it being psychosomatic, e.g. it's in somebody's head, And I think it's a follower from that because it's similar. It's post-viral. A lot of ME is post-viral. And for many, many years, patients have been treated like they either haven't done anything to help themselves, or they're not really that ill, or it couldn't possibly be that bad, or they're might have people saying they're the type of person that would get that sort of disease. So a lot of stigma around post-viral illness, and it would have been highly expected from the SARS-1 incidents that lots of patients wouldn't recover.
You mentioned stigma on at least one occasion in your statement. If now can't actually find where it is, so apologies, but you do mention it.
Yeah.
Is that stigma a difficulty, first of all, for patients themselves?
Absolutely. I think it causes them problems with work. It causes them problems with accessing healthcare, with maybe friends and family. And if you look at the way long COVID is written about in the media, depending on who's writing it, you can see that they are not taking it seriously. These patients are extremely unwell and can't do the things that they used to do. So definitely for the patients, I would say having a diagnosis of long COVID can be very difficult for them.
Is the stigma still the same now as it was, say, 2 years ago?
I think it's still the same, yeah.
We heard from Mrs. Ormerod this morning, and she referred to the stigma in particular in relation to children.
Yeah.
Now, I know you don't treat children, you don't treat anyone under the age of 16,
Yeah.
but from your own perspective and your own knowledge, is the stigma attached to children with long COVID particularly damaging?
Absolutely. I might not treat them until they're 16, but I've got their history when I see them at 16 for maybe the last couple of years of their illness, and they've had the same things said to them. Patients will tell me what they've had said to them. I've been told that I need to just get back to doing what I was doing, but they can't get back to what they're doing, which might be school, for example, because they're too unwell. And in that age group, telling these children that they just need to try harder when they've had a virus that has multi-system effects, and then nobody's treated those multi-system effects, I think is particularly damaging for them and their trust in healthcare.
Thank you. Can we look at some of the symptoms, please? And again, we had the benefit of Mrs. Ormerod's evidence this morning. I think you were aware of it. And so she's described some of the symptoms. You describe them at paragraph 44 of your statement, and I'd like to look, please, at the first three of those. The first is extreme fatigue, and it may well be that, I suppose, post-exertional malaise is attached to extreme fatigue. That may be a manifestation of it. But how do you categorize or characterize extreme when you're describing fatigue?
So with ME/CFS, there is a severity scale, but there isn't for long COVID. However, the most extremely fatigued patients I have could maybe tolerate 10 seconds of talking to somebody for a whole day. The most extreme are in darkened rooms. They have to cover their eyes for the light. They can't get out of bed to go to the toilet. That's the level of fatigue people can have. You have a spectrum of people who might be mildly fatigued, and that they are not able to do what they wholly used to do before COVID. But most of my patients would fall into the category of housebound or nearly housebound or bedbound.
We'll come to housebound because you have a section on that. But post-exertional malaise, or PEM.
Yeah.
I mean, we've heard some evidence, I think, there's reference to it in Mrs. Ormerod's statement about people feeling so fatigued that after putting a pan on the cooker, they forget about it, or they're unable to go back to switching it off. Is that an instance of post-exertional malaise?
I would say that it's slightly different.
Right.
So post-exertional malaise can develop immediately or in the next 1 to 2 days after activity.
I see.
Whereas that would be their cognitive problem if they're forgetting. But the post-exertional symptoms can last for several days after an activity.
Mm-hmm. And I think in your statement you say that for some people PEM can even be triggered by talking or sitting up.
Yeah, so I would, anybody with long COVID who gets post-exertional malaise, and what tends to happen is they get COVID, they're not getting better, and then they might try and go back to work, for example, and they find that they might manage that day they've done, and then they're in bed for 3 days afterwards, and they don't know why. They've suddenly not been able to manage a day at work, for example. But for others, it can be, for these very severe patients, as simple as sitting up can actually make it. Everybody will get a different experience of post-exertional malaise, and some patients tell me it feels like they've been poisoned. Other patients tell me that it's like having the flu, and for others it's just they cannot do anything. The energy systems of their body isn't working properly, down to the cellular level. And that's what it has in common with ME, is that these patients, in most of the ME diagnostic criteria, is post-exertional malaise as having to have that to have ME. And that's why about 50% of long COVID patients meet the criteria for ME, is because they have this post-exertional malaise. But malaise is a funny word to describe it, given how unwell people can feel, and it isn't tiredness. It is, I think what I gather from it is like their entire body is dysfunctioning, and if you got it today, you might take yourself off to hospital type of level, but they know now what they've got